Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of a male who presented to our ER with complaints of fever with productive cough. Can we begin, sir?
Yes.
So there's this 56-year-old male patient who presented to our ER with complaints of about roughly a week history of fever associated with productive cough and insidious onset, progressively worsening breathing difficulty. So in our initial 10-second assessment, patient was conscious, oriented, obeying to our commands. And in our primary survey, airway was patent with air entry to be bilaterally equal. C-spine appeared normal, no pooling of saliva, no increased secretions noted. Breathing-wise, patient had a respiratory rate of 22 cycles per minute, maintaining saturation of 95%, 94-95% on room air. But he had increased work of breathing, so there was respiratory distress noted.
But rate is not high, no?
No, 32 cycles per
32.
minute. 32 cycles per minute, maintaining saturation of 95% on room air with increased work of breathing. He was tachypneic and usage of accessory muscles was also noted. Now, along with this, circulation-wise, he was tachycardic with a heart rate of 113 beats per minute, maintaining blood pressure of 100 over 70 millimeter mercury. All peripheral pulses were warm and palpable.
Okay.
So, disability-wise, he had a full GCS score of E4, V5, M6 with pupils being 2.5 bilaterally reactive to light. And exposure-wise, he was having a normal body temperature and had blood sugar levels of 280 milligram per deciliter. So from our primary survey, what we see is that the patient had increased respiratory distress. Along with this, patient was tachycardic, but it was regular in rhythm, and he also was noted to have uncontrolled blood sugar levels. Now with this, our primary adjunct was a arterial blood gas which showed respiratory alkalosis with a pH of 7.54 and a bicarbonate of 24.6 and a PCO2 of 24.6 and a bicarbonate of 21.3.
Okay.
And our PO2 levels were about 82.5.
Okay.
So it was a acute respiratory alkalosis, and lactate levels were 2.3, 24.3,
Okay.
and our lactate levels were slightly on a higher end of 2.3.
Okay.
But apart from this, we took an ECG and it just showed sinus tachycardia. Along with this, patient had T-wave inversions in the anterolateral leads.
How do you differentiate sinus tachycardia from SVT?
So in SVT, there will be absence of P waves
Mostly.
and the rhythm will be regular. So it is a narrow complex tachycardia with absent P wave. Sinus tachycardia, since the rhythm generates from the SO node, it will have a P followed by QRS plus it will be tachycardia.
Okay.
And SVT will have more higher heart rate, like way more than 120, 140. But sinus tachycardia generally is not that high.
Okay.
So this was the ECG finding. So apart from this,
T-wave inversion V1 to
anterolateral leads.
V1
so
to V6.
1 AVL, V1 to V6.
What type of T-wave inversion they are?
They were symmetrical but shallow T waves. They weren't deep T waves.
Okay.
So
So most of the leads T-wave inversion is there.
yes, sir.
Most of the
leads
leads.
it was there.
That
So,
indicates what?
Either a diffuse, it can be a ischemic changes.
It's more like a global issue.
Global issue. It is mostly indicates a carditis. Mostly because of the infection or whatever it is.
So those were our adjuncts, and we also took an ABG and found to have no acidosis. Considering how the patient was tachycardic with increased work of breathing plus uncontrolled blood sugars, diabetic ketoacidosis has to be kept in mind, since this patient was also a known case of diabetes mellitus on OHAs. So no acidosis was noted, so we did not really think of DK at this point in time. So it was just an uncontrolled hyperglycemia. So apart from this, at this point in time, we cannulated the patient with 2 large bore IV cannulas, and then we, according to the ABC, we had to handle his airway and breathing part, which suggested that the patient was in distress. So considering how patient had increased work of breathing, we put the patient on a non-invasive ventilation.
Okay.
That's a BiPAP.
What are the indications of NIV in ER?
One, if the patient has increased work of breathing with tachypnea, like secondary to acute pulmonary edema, ARDS, or if the patient has PCO2 buildup, then like in cases of COPD or acute exacerbation of asthma, we put the patient on NIV, provided the patient has a full GCS
Okay.
and he is obeying to our commands, and because coordination with the machine is very important for BiPAP to be successful. So the idea behind BiPAP is we'll have an inspiratory pressure and a PEEP, sir. Whereas in oxygen masks, all these will only provide oxygen. There's no pressure build-up in there. But a better thing before attempting NIV would be a HFNC.
Okay.
That's the high flow nasal cannula.
Where will you
before-
use HFNC? What is the ideal condition for HFNC?
Mainly type 1 failure.
It is type 1
hypoxia.
failure. It is only hypoxia. There is a hypercarpia, then NIV is best.
So this would be the conditions, or pneumonia, wherever there is increased work of breathing and patient has requires inspiratory pressure for ventilation, for proper ventilation. So and this patient on auscultation, even though his air entry was bilaterally equal, he was noted to have scattered crepitations predominantly on the basal areas posteriorly, but both the lung fields had crepitations upon auscultation. Then no Kussmaul's or Cheyne-Stokes breathing or abnormal respiratory pattern noted. Acidosis. Nothing of that sort was noted. Then usage of accessory muscles with this. So in short, patient had respiratory distress. So apart from this, since the patient was also a little hypoxic,
Potassium value in this?
Potassium was 4.3. Yeah, 4.3. So. Then apart from this, so we maintained a target saturation of about 95%. And then moving on to the circulation aspect, the tachycardia was one secondary to the respiratory distress. So we didn't do anything much about it. And blood pressure was now 100/70. And we were just keeping the patient on close monitoring. Then on systemic examination wise, apart from this, other systemic examinations were normal limits. So coming on to the sample part, patient was a known case of diabetes mellitus for about 8 years, and he was on OHAs, on and off OHAs. No Ayurvedic medications, no other comorbidity was noted in this patient. So it just so happened that from 2nd of November, he developed low-grade fever. About a day later, he also developed insidious onset, progressively worsening breathing difficulty and productive cough with whitish sputum of. Then he also had generalized weakness and 2 episodes of loose stools, non-blood tinged, but not associated with any abdominal pain or any other GI symptoms. Now, apart from this, he also complained of having dysuria, but there was no decreased urine output, hematuria noted, no altered sensorium, no palpitations or chest pain in any of these episodes. So with this, our diagnosis was the differentials that we went on about was LRTI, lower respiratory tract infection, causing uncontrolled blood sugars. Along with this, possibly an NSTEMI versus a raised cardiac enzyme secondary to sepsis, and a possible UTI also. So this was with this differentials we went about it. First we hydrated the patient, started the patient on a
How do you
balanced.
decide to hydrate the patient? What are things you have to...
One, we can look for signs of dehydration clinically, sir.
Is there any sign of dehydration in this patient?
In this patient, only tachycardia, but tachycardia can be attributed to a lot of other causes too. Then dry tongue can be noted. Along with this, the other dynamic ways of noting is lactate levels, that signifies hypovolemia. Urine output, if it is decreased, signifies hypovolemia. And IVC. So IVC has to be looked into. If it is more than 50% collapsible, then patient has fluid deficit. Otherwise, also we can give plasma light as a bolus and fluid
What is
challenge.
passive leg raising test?
In this patient, what we do is the patient will be kept supine and then the bed will be tilted after connecting the patient to the cardiac monitor and the blood pressure monitoring. So after if the patient is hypovolemic because of increased preload of increased venous return, patient's systolic blood pressure increases by more than 10 millimeter mercury. So in that position, because of that gravitational pull,
Okay.
BP increases. So that signifies hypovolemia.
So that indicates what? You can give more
More
fluid.
fluids.
Patient
Fluid.
can be given more fluid.
fluids.
Okay.
So these would be the tests that can be done bedside in order to figure out whether the patient will be fluid responsive or not. So we
Okay.
started the patient on IV fluids.
What fluid you have started?
A plasmalite, which is a most balanced fluid now. So plasmalite was initiated at 30 ml per kg within 3 hours of patient's arrival, and then the dose can be the boluses can be repeated up until the point where the patient either goes into fluid overload state or the patient's hemodynamic status improves. So in this
What are the
patient,
contraindication for plasmalite? It's a safe solution, most physiological solution. Tell some contraindications. Hypermagnesemia. Hypermagnesemia is the only possible contraindication for plasmalite because it contains large volume magnesium. Okay.
okay. So in this, we had to cautiously use fluids because patient had crepitations, patient had tachycardia, and raised cardiac enzymes too. So we didn't know if the patient was going to go into cardiogenic shock or had an underlying ARDS or acute pulmonary edema secondary to sepsis
BNP?
caused by BMP outside and both the values were elevated, 4,700. So we only gave a fluid challenge, following which patient's BP picked up. So we didn't really have to start the patient on inotropes. If at all the patient BP wouldn't, or he had persistent hypotension, we would have thought of early inotropic agents
What
in this patient.
inotropic agent is normally said?
Our first choice would be noradrenaline, sir, because it's a vasopressor. And if at all patient has cardiac involvement, then once the BP picks up, we can add dobutamine to it. But if we really want another vasopressor agent, then vasopressin will be our choice.
Okay.
Now, any of this during resuscitation, if the patient develops bradycardia, then dopamine will be our go-to drug.
Okay.
So these would be the inotropic agents of choice. And then
What is the major difference between adrenaline infusion and noradrenaline infusion? Both are vasopressors, strong vasopressors, similar action, slightly more in the adrenaline group. But what is the major difference?
I think central will increase the heart rate.
Heart rate. Heart rate will increase like anything in adrenaline, but not very much in noradrenaline. What is the side effect of adrenaline infusion in the heart? Heart.
Can increase the myocardial.
What is that condition called as? Acute cardiac ballooning. What is it? Takotsubo.
Takotsubo.
stress cardiac.
Same thing. The name is Takotsubo.
Takotsubo.
Okay, so that's why adrenaline is not used nowadays. That is also equally powerful or better than this. Okay. Can we give noradrenaline through peripheral lines?
It causes, initially, by the time we secure a central line, initially for a faster resuscitation management, we can choose a peripheral line provided the line is in a 18 gauge or a higher large bore cannula and more proximal to the heart. So cubital and above we can secure. And then if it is long standing, then we'll have to opt for
If you
central
don't
line.
opt, what will happen?
There will be extravasation of NORAD causing phlebitis, vasoconstriction.
Gangrene, peripheral gangrene.
Vasoconstriction.
Severe vasoconstriction in the peripheral blood vessels and produce gangrenes.
Gangrene. So this is how we would deal with the airway, breathing, and circulation parts. So now the other thing that we have to notice is that the patient has uncontrolled blood sugars, and considering how the patient was in sepsis, so we'll start the patient on insulin infusion rather than intermittent doses of insulin. So we'll
Is there
start.
any real advantage over insulin infusion or insulin subcutaneous?
We'll have a better control, sir.
You
If
can,
at all patient is
when you
sepsis.
want to stop, you can stop. That's all. What is the difference between infusion and subcutaneous? One is when you want to stop, you can stop it.
Second, actually, depending on the hydration status,
That is very important. If you are giving subcutaneous, then hydration status has to be corrected. If you correct hydration status, if you want to give subcutaneous, you can give. Otherwise, don't give. It will not get absorbed.
So in this patient, we started short-acting human actropid as our insulin infusion dose, and the dosage of zero point 0.1 international unit per kg per hour. So we started at around 5 international unit per hour, and when we start the patient, then we'll have to monitor blood sugar level at least once every 2 hourly, and potassium levels have to be checked into because insulin infusion causes hypokalemia. So this is how we would deal with the, and we can send serum ketones in order to see if the
Okay.
patient has ketonemia or not. Then by this time we had blood parameters come in, wherein we noted that the patient had a procal of 24 with a CRP of 290 and total counts were around 27,000. So patient, like we suspected, had sepsis.
Bacterial infection with sepsis. Evidence of bacterial infection is
Serum
procalcitonin.
procal. Yes, sir.
Evidence of sepsis is
One sepsis, basically by definition, it is organ dysfunction with end organ damage. Any foci of infection with organ dysfunction would be the definition of sepsis. So we have the foci as either urinary tract infection or lower tract infection.
tachycardia, tachypnea,
sepsis.
elevated count or reduced count, lactate levels. All these things can be used for definition of sepsis.
So then now when we are dealing with sepsis, within 3 hours, we'll have to go with the whole sepsis protocol, where we have 1 hour bundle, 3 hour bundle, 6 hour bundle. The idea is to start fluid resuscitation or inotropic agent within 3 hours at the rate of 30 ml per kg per hour, provided if at all we are strongly suspecting sepsis, then within 1 hour. But if we are giving a benefit of doubt, then within 3 hours. Then apart from this fluids, then we will give IV antibiotics. Here we'll be thinking more in terms of community acquired pneumonia.
If it is community acquired pneumonia, what type of pneumonia it is?
A positive, gram positive, staph, strep 2.
What is the duration of the illness?
About a week.
1 week, patient had mild fever, progressive problem, and now also chest X-ray shows bilateral minimal infiltrates. What type of pneumonia is suspect?
It will be atypical.
It has to be atypical. Clinically, it is atypical pneumonia, not atypical pneumonia. Typical pneumonia, what will be the clinical finding?
There will be consultation, one patch will be
High degree fever, chills, rigors, breathlessness, hemoptysis. X-ray shows consolidation. Okay. Here bilateral infiltration, slowly progressive disease, more in favor of a atypical pneumonia. Whereas in viral pneumonias,
It will only be increased bronchovascular markings.
there you have upper respiratory finding, cough, breathlessness in 2-3 days. Immediately patient develops chest X-ray finding. Okay, so that's how you differentiate atypical pneumonia and viral pneumonia. And procalcitonin is also high. That indicates bacterial infection. Sometimes viral pneumonia, on top of viral pneumonia, patient can develop staphylococcal infection, secondary infection. Okay, whatever it is, there is a bacterial infection.
And this patient also had associated GI symptoms of loose
Diarrhea,
torsion. So again favoring towards atypical pneumonia.
pneumonia.
So our antibiotic of choice was to cover up gram positive, negative, and also the atypical coverage. So we went ahead with piperacillin, tazobactam. Ideally, that would have been enough, but the reason why we added azithromycin is because azithromycin has an added anti-inflammatory action.
If you
on
want
the lungs.
to start a single antibiotic, what will you start?
Respiratory clonulons.
Levofloxacin or moxifloxacin? What is the coverage of moxifloxacin or levofloxacin?
Gram negative.
positive, negative,
Gram positive, gram negative, anaerobes, atypical. All will be covered normally. Normal settings, that is more than sufficient. Okay.
So IV antibiotics also has to be started. By the way, chest X-ray findings, like we discussed, it had patient had bilateral heterogeneous carotid infiltrates with features of pulmonary edema, like that homogeneous opacity is predominantly in the middle zone of the lung fields would signify pulmonary edema with curly B lines.
Okay.
And then
So how do you treat that pulmonary edema here in this patient?
one would be keeping a close monitoring on blood pressure and starting the patient on NIV and diuretics.
What is a disadvantage of starting NIV in a patient who is in hypertension?
For the worsening of
Okay, it can occur.
hypertension
Worsening
because
can
of
occur.
pressure changes.
Okay.
Then furosemide, diuretics.
What is the BP of this patient?
Borderline, so
So how
170.
do you start furosemide in this patient?
We can give a bolus dose and then intermittent bolus doses would be enough.
Okay.
Or if you're starting infusion, then a low dose infusion can be started.
Infusion will be better in this patient because already BP fall is there. Okay. IV push can produce BP fall.
BP fall.
Okay.
So we gave a start dose, and along with that, we started a low dose infusion in this
Okay.
patient. And then bedside echo was done, and it showed no RWMA, concentric LVH with good LV, and ejection fraction was
He's a
about
diabetic
50%
patient.
diabetic.
What type of cardiac failure they can have?
Diastolic.
So what will happen to ejection fraction?
Ejection fraction will be preserved, and the patient can have heart failure.
Heart failure. That's called as
Reduced
heart failure with preserved
preserved
ejection.
ejection fraction.
So what is the treatment for that? Fluid restriction. Fluid restriction and fluid removal is the treatment. Okay. So minimal fluid itself will produce volume overload because heart is not taking any more fluid. So that will accumulate in the lungs. So we have to be very careful if there is a patient who is having cardiac failure with normal ejection fraction. Okay.
Now, along with this, our urine routine also showed features of urinary tract infection with the pustules being 15 to 20, and patient also had an associated acute kidney injury with a creatinine of 1.8, and sodium was found to be 124.2. Workup showed more in favor of renal failure causing hyponatremia. So
What is the creatinine?
creatinine 1.81, sir.
Okay. Creatinine
And
clearance.
urea is 61.4.
Creatinine clearance.
Creatinine clearance was 53 or something. So
53. It cannot be 53.
43, 53.
If creatinine is increased,
Just
means
check
it has to be less than 50. 2 means it may be 25 or 26. If creatinine is 2, creatinine clearance will be less than 50. If creatinine is 4, creatinine clearance will be less than 25. Why this is important?
For antibiotics,
An
clearance.
antibiotic dose adjustment, that's all. Okay.
So apart from this, the other electrolyte and also hypomagnesemia was there. Magnesium was 1.2. Then cardiac enzymes elevated, pro-BNP 4000.
Tell about magnesium deficiency. What do you know about magnesium deficiency? This is 1.2. Our lab is somewhere around 1.8 normal value.
1.6.
Do you
yes,
think it
sir.
is a minimal deficiency or very big?
Significant?
How do you know that? There is a problem of magnesium. How much amount of magnesium is there in the intravascular compartment? Total body magnesium, how much is there in the intravascular compartment? It is only 1%. 1 to 2% of total body is there. So even if there is a deficiency, it does not reflect the total body deficiency. It only it tells you that there is deficiency. And when you correct only, you know that whether it is getting corrected, it is becoming 1.8 or more. Okay. So you may require large quantity of magnesium in this patient. Where magnesium is useful in this patient? What are the actions of magnesium?
Cardiac
Arrhythmias, it can be used. Then
if the patient has hypokalemia, then correcting
hypokalemia, magnesium has to be given to correct the
first,
potassium level. Then
can improve the ventilatory effort of the patient.
Muscle action, ventilatory, patient can have weaning difficulty. Then most important in this patient has got some important problem. What is that problem? Uncontrolled sugars. What is the action of magnesium on insulin? Insulin improves the intake of magnesium into the cells and action will be improved. So if there is no magnesium, there is no action of insulin. So you'll have to give more insulin. So if you don't correct magnesium in this patient, insulin will not work. Okay, so better to correct that insulin. How do you correct magnesium?
We can give IV injection, 2 gram mixed in 100 ml NS. We can give it over a span of 20 minutes.
Okay, how do you know that the patient is going for a hypermagnesemia?
That reflexes.
Knee jerk. Knee jerk is the easiest thing, but you have to always check your magnesium levels. ECG should be monitored. Okay.
Yes. So these would be the dyselectrolemia, then urinary tract infection, sepsis, acute kidney injury, and LRTI.
Okay.
So easiest thing is to do the curb 65, admit the patient in ICU,
Okay.
and then along with this, so patient during the course of his stay here, he improved. We tapered him off BiPAP, put him on intermittent spacing of NIV, and he was pretty much tolerating. Then
Okay.
we weaned him off BiPAP also. Now he's currently on Rumer. Then with due course in time, the
What
antibiotics
happened to
were
the X-ray finding? Is it improved?
clearing. So,
Clearing.
first the edema features, pulmonary edema features cleared out, but
Okay.
infiltrates are still present, but it's now reduced in proportion.
Okay.
So then his HbA1c is also 11, so it was uncontrolled blood sugars.
Okay.
So that was also like we maintained a blood sugar target of 140 to 180 milligram per deciliter in the ICU setting. And patient was mobilized early, so that's how we took care of the DVT prophylaxis. And patient tolerates oral feeds.
Okay.
So he improved
He improved.
instant, yeah.
Okay. What else you want to add?
Only thing is that actually, in ED, this kind of patient actually really having a difficulty in putting him a diagnosis because he's mainly coming with respiratory alkalosis and distress. So we can go for a lung ultrasound in ED itself. One thing is we can rule out any acute, any mild pneumothorax or maybe some pleural effusion, and also if multiple B lines are there, we can contribute it more to a pulmonary edema. And also if we can see any consolidation in the USG itself, we can have a basic even before taking an X-ray. There's an delay in X-ray or anything like that. So application of ultrasound will be a good thing if you are having a difficulty in diagnosing this kind of patients. Also differential diagnosis, actually we have to think about other causes also in this kind of patients because the X-ray is not giving a very clear picture of proper LRTA. So we can think about other causes like maybe a cardiogenic heart failure, like congestive heart failure with pulmonary edema. Then pulmonary embolism that we think about.
When you think about heart failure, we always think about systolic failure. Diastolic failure is another important condition which can present like ARDS. When you do echo, everything will be normal.
Then again, pulmonary embolism can also be one this thing DD because of initial hypoxia, tachypnea, tachycardia, and all that. And also maybe other things like any pneumonitis, any atelectasis, any previous bronchitis, any history, is there any exacerbation, any ILD, sarcoidosis, all these multiple differences can be thought about if we are not able to conclude with a basic diagnosis. So any patient coming with like probable LRTA, we can classify them as a community acquired or maybe nosocomial acquired. Nosocomial means again hospital acquired or again ventilator acquired. Hospital maybe about after 48 hours he's developing an acute illness. This could be attributed to a hospital acute pneumonia. Again, after post ventilation 48 hours he's developing an acute new and LRTA. It could be associated with ventilator associated. So these are the basic classifications. So our basic assessment as we discussed will be curve 65 in which we have confusion, then in urea about 20 milligram per deciliter, then age about 65 and respiratory about 30 and hypertension is systolic BP less than 90 and diastolic less than 60. If any one is 0 or 1, we can either give some treatment OPD basis or send them home. 2 will be award admission and 3 will be ICU admission. To add on that, this patient is requiring any kind of NIV or any hemodynamic instability, it definitely requires ICU admission. So this patient has multiple issues. One is a probable LRTA with a probable heart failure with uncontrolled sugars. So ideally, he should be put in ICU. And our management again will be like difficult because actually one side we have to restrict the fluids and everything, but on the other side the patient has some like could go for like a hypercoagulable state because of high glucose. So we have to judicially plan the fluid management because actually we should not push him to an overload state, and same time we have to adequately manage the hyperglycemia also. So we target our fluid management according to our urinary output and intermittent IVC assessment and also other parameters, and also depending on that we can actually correct the fluid levels also. Again, initially we go for like a higher level antibiotics, and depending on the cultures then we de-escalate once the report comes. But the patient actually clinically improved even with 1 day or itself, so probably the actual positive organism maybe like not that severe kind of. So thinking about organisms again can be like typical organisms, atypical organisms, or viral. So this patient, it could be an atypical or maybe even viral, could be an
How do
atypical
you
also.
diagnose atypical here?
Atypical, this thing.
GI symptoms
No,
associated.
that is clinical. GI symptoms is what then? Hyponatremia,
Hyponatremia.
hemolytic anemia, altered behavior. These are the signs of atypical pneumonia. Different pneumonias will have different features. Now, how do you diagnose it?
Excellent.
Another thing about like,
Ethical serologies.
Serologies,
Ethical serology test for all these things because it is coming as a panel.
You can go for a typical panel.
Mycoplasma, Legionella, all these things. Legionella, from where you get
AC.
ACs, infected ACs. They have more
Conferences.
diarrhea features. Okay. Mycoplasma,
Again, diarrhea.
Diarrhea.
hemolytic anemia.
Hemolytic.
Yeah. So this patient is currently improving and is still in ICU. So pretty better.
Sir, and the other thing is hyponatremia can be secondary to hyperglycemia. So whenever there is hyperglycemia, then it is a pseudo hyponatremia. So we'll have to do the sodium correction.
How do you
For the
correct it? Correction factor.
So anything above 100, we add a correction factor 1.6 up to
2.4.
so up to 400.
Okay.
So if the sugars again is above 400, we put a correction factor 2.4. Like that. So basically, it can mimic like a pseudo hyponatremia.
Okay. Which all conditions will produce pseudohyponatremia?
One thing is hyperglycemia, then giving any mannitol or any other osmotic, this thing.
Hyperlipidemia.
Then any hyperlipidemia, all those conditions can. So whenever we are calling it hyponatremia, first we have to rule out all those conditions initially itself. Like that. That's all.
Anything? Thank you.